Good afternoon, everyone. We're back for the afternoon session of day one, Special Populations to Ethnicity. So I'm going to go ahead and get started with sharing my screen so that we can get back to where we were. Hopefully, if you chose to, you had a nice break and or an opportunity to look at or listen to and look at the questions that we posed with regards to the pharmacogenomics research segment that you listened to from NPR. So this is where we left off yesterday. It was on not yesterday, this morning, I guess in the earlier session from again, slide 91. And this were the questions that I ask you to consider. Given that we don't have live interaction during this recorded segment, I am going to go ahead and again ask you to post your answers to at least two of the questions or two new questions, one or two new questions that of your choosing or comments that you have about the segment to the Canvas portal. So this questions are on slide 92 and 93. So this would have been the end of the morning lecture, slide 94, and we're going to continue talking about environmental factors in the interaction between genetics and basically nature versus nurture with regards to psychopharmacology. I want to just kind of keep to the same format that we were doing before. We're going to save the poll questions to our live lecture, but we will be taking some breaks, or I will be taking some breaks during my recording. Hopefully you'll take breaks as you're listening to, so you can integrate the information and learn best or better. And so with that, let's go on. So in slide 95, we start talking about the environmental factors specifically related to dietary habits. So here's a question that I would like to pose. Does it matter if your patient had a cup of coffee, a martini, a carafe of wine, maybe not, maybe one or two of the two, not both, or grapefruit juice, and a charbroiled burger, Brussels sprouts, and a cigarette for lunch? Again, doesn't matter in general. That's not the question from a psychopharmacology perspective. Doesn't matter. And could any of this be culturally related practices, right? What if any aspect of this dietary habits could potentially be a culturally relevant practice? So let's dig down. Answer is it does matter. Flavonoids in soy and red wine, so in the carafe of wine, would lead to inhibition in the 1A1, 1A2, 2E1, 3A4, cytochrome CYP450 enzymes. Fruits and specifically the bergamottin and grapefruit juice is a 3A4 inhibitor. You would likely have heard that before or in other classes. Cruciferous vegetables, including broccoli, sprouts, Brussels sprouts specifically in this example, and cabbage, can lead to 1A2 induction. Charbroiled beef can lead to 1A2 induction as well. Caffeine and smoking can also cause 1A2 induction. And alcohol, so the martini specifically, but also the wine, can lead to 2E1 induction. So needless to say, this is a quick way to point out how dietary factors and potentially those that are, culturally relevant do matter. So let's dig down a little bit more. Remember this wheel? We talked about the bi-directional relationship between things like dietary factors, drugs. I'm sure alcohol is listed there. Tobacco is listed here. Alcohol intake, and multiple other things have the relationship that they have with our genetic constitution. So regardless of, potentially, metabolizing status, all of these things mentioned in the previous slide can cause induction or inhibition, which means that the genetic composition, the genetic constitution is being altered, or is manifesting differently. So we know already from this example and from previous classes that dietary habits can affect pharmacokinetics because they affect the body's ability to absorb, distribute, and metabolize medications. Again, that's a given. That's something that you've already learned in other classes. For example, a high protein diet has been shown to enhance drug metabolism through increased oxidation and conjugation. So how many of us typically ask our patients about dietary habits? How many of your patients do you know that follow a potentially low carb, keto, you name it? There's different high types of high protein diets that people engage in. And do we know that about our patients? And do we need to know that about our patients again when doing a biopsychosocial assessment? And how much of this is affected by migration and cultural changes. For example, as you could see on slide 98, Asians and Africans who were exposed to a Western diet and environments do not exhibit the same sensitivity to psychotropics as those living in their native countries. So what else, is it not just the diets, but again, what else is in the environment, including sunlight exposure, including some behaviors, other health behaviors, and environmental exposures like toxins that could potentially change somebody's pharmacokinetic status. Um, so this is a graph that helps us to see, for example, the impact of ingestion of grapefruit juice on the metabolism of a sample drug, in this case, philodipine, over the course of time. So I know it's kind of blurry to see this, but what you see in the on the X bar is the philodipine concentration. So this is the drug concentration on the vertical line. On the horizontal line, you see the differences between ingestion of 8 ounces of water versus one not 8 ounces of water, but just regular water ingestion versus 1 8-ounce glass of grapefruit versus 5 days of 3 daily administrations of grapefruit. And as you could see, the concentration of the drug rises sharply as you increase the intake of grapefruit juice because of the essentially by inhibiting the CYP3A, the grapefruit acts as a basically, increases the bioavailability of the drug. And this is just one drug example. As you know, that could be true of multiple drugs, especially those that are metabolized by the 3A4 system. Here's some other examples. Nothing you need to memorize here, but just, for your general awareness, look at examples of herbal products and medications that could be affected that either lead to induction or inhibition in the cytochrome P450 enzyme. So, for 1A1, nutmeg is an inducer. Here's a drug that could be potentially affected by that. 1A2, things like ginseng, kava, nutmeg, and SGW, which is St. John's wort. As you know, it's a natural supplement that some people use to self-treat issues of depression or anxiety. So very important natural nutritional or herbal product to know about. But ginseng and kava and ginkgo, by the way, listed there, are also commonly used supplements or products, especially in certain communities. And look at how many drugs may be affected by this, including amitriptyline, clozapine, diazepam, and even oral contraceptives. Just to name a few. So just, kind of take a look at this. Again, what I want to make sure, again, not to memorize, but to bring awareness to the fact that many things can cause many uh, herbal products or, nutritional dietary supplements can bring about induction or inhibition in a way that could potentially affect the metabolisms of drugs that are commonly used. Um, Again, things, that people, even things that people consider to be relatively um, benign or, non, non, not problematic, such as garlic and that sort of thing. And of course, we're talking about large quantities. Okay. So you know that genetics anything related to our genetic composition is subject to sequencing variation, DNA sequencing variation. And that's what a polymorphism is. So when we talk about polymorphisms, we're talking about an inherited DNA sequence variation. Meaning we have different forms of the same enzyme. And in the next few slides, I'm going to spend a little bit of time giving you a visual representation of what that means. Only because I know that you have this knowledge, but again, I am kind of a visual learner and I appreciate kind of, seeing what this means and being able to, integrate that knowledge. Plus repetition doesn't hurt, especially as you're winding down your training. So because of these polymorphisms, because of these genetic variations, we have people who are poor metabolizers, intermediate metabolizers, normal, quote unquote, or extensive metabolizers, and fast or ultra rapid metabolizers. And those are the terms you're likely to hear me use. Poor, quote unquote, normal, or which are, either intermediate, normal, or extensive metabolizers, and fast metabolizers. This is just one way that they're separated. So as a distinction, the poor metabolizer is unable to produce a CYP enzyme or has only one functioning allele. Or variant alleles with less enzyme activity. And maybe that they have two active alleles, but they're variant alleles that have less enzyme activity. And as a result, they show slow or no drug metabolism, depending on what enzyme, whether sequencing variation or their DNA variation exists. And would show high plasma levels of the drug at a normal dose. No normal dose being the standard dose. Um, the intermediate metabolizer may have two deficient alleles or one deficient allele and one non-functional allele. And they would show, perhaps slower metabolism than the extensive metabolizer, but not as slow as the poor metabolizer. But they would also show increased plasma levels at the normal dose. A normal or extensive metabolizer has two normally functioning alleles, and so you would expect the standard response to this the standard the standard concentration of the drug or the standard dose. And then the fast or ultra rapid metabolizer is going to have three or more functioning alleles, so they have a little bit of an advantage if you want to look at it that way. It isn't necessarily a genetic advantage; it's just the way it is. So they would have lower drug plasma concentration despite the therapeutic dose, meaning they metabolize it too quickly for it to have the effect on the body that it's supposed to have. And as a result, they're going to have no drug response at the ordinary dosage. And this would be the so-called non-responders potentially. So again, not a real advantage. It just depends on, how we look at it. Okay, so here's what I just said, essentially in pictures. If you look at, the top of the chart, well, let's look at the key in the bottom. That green bar is a fully functional allele. A yellow bar is a functional but impaired allele, so variable of the normal, quote unquote, allele. The blank bar, so, basically non-color, is a non-functional allele. And then the basically uh, the dotted line or the dotted bar, it means deletion of the full gene. So the full gene is not even present. So those are at the top of the bar, you have the genotype, um, where somebody who has three or more functioning alleles turn into a phenotype of an ultra rapid metabolizer. An extensive metabolizer, again, two functional alleles, or one functional and one slight variation. Um, and they would be considered an extensive metabolizer, and that's going to be the majority of the population. This people figures down below, that's what is showing, is that the majority of the population are going to be extensive metabolizers. The intermediate metabolizer is either going to have two variables or two slightly non-functional or functional but impaired alleles, or one impaired allele and one non-functional allele. And the poor metabolizer is either going to have two non-functional or one functional and one deletion of the gene. And that's what make them a poor metabolizer. And then right at the bottom before the key, you see that what that translates to in terms of dosing. So where an extensive or intermediate metabolizer, and this is drug X, so not any specific drug that you should know about, but just again to understand the concept. An extensive or intermediate metabolizer, it would respond or be expected to respond to a standard dose of 100 milligrams. The the ultra rapid or fast metabolizer would require 5 times that much, or 500 milligrams. Again, this is just an example of a drug, so it may not be 5 times in any other drug per se. Whereas the poor metabolizer would require potentially a tenth of this drug. So very minimal dosing compared to the extensive or the intermediate metabolizer. So for all intents and purposes, non-responder on this end, a responder with very serious, potentially life-threatening side effects at this end of the scale. And we wouldn't have any way to predict that, just by knowing those things. But you will run into people, I'm sure you have already, that have are very sensitive to medications. They're potentially already leery, about use of medications because they've had bad experiences. They react, if there's a side effect to be had, they're going to have it. Or the opposite. They think that medications aren't going to work for them because of their fast metabolizing status. I had a supervisor when I did my practicum, who was a geropsychiatrist, and would say, sometimes the dosing for a poor metabolizer is so infinitesimally small that licking the medication would cause side effects. That was her way of pointing out how this might be problematic. And I mean licking the tablet. Okay, so we do know that polymorphisms you know, are are rare in the general population, but they are frequent in some subgroups. So look, for example, and this is an example. This is data from the AmpliChip website. So take it for what it's worth. And I haven't updated this in quite a while because once again, I only use it as an example. I just want to make sure that you don't take these numbers too hard, or as gospel, but that you understand that there are subgroup differences with regards to polymorphisms. And this is specifically relating to CYP2D6, which is important in the metabolism of a lot of psychotropic medication. Look, we got normal predicted enzymatic activity in a large number of the population in Japan and China and the US. In general, US Caucasian, I'm sorry, Caucasian in the European Union, Caucasian in the US, um, Black American and Black African, but the numbers are different. then you see the highlighted areas some issues with potential polymorphisms, in the in this um, 4 allele for Caucasians in the European Union and the US, for Japanese and Chinese on number 10, for Blacks and African American and Black Africans for 17, and in Caucasians in the European Union in 41. So again, um, it's limited data. It's just to give you, and again, take it with a grain of salt because it is generated by a pharmaceutical company, or both a pharmaceutical and medical device company. But it does give you an idea of how, there are population differences in genetic polymorphisms. Okay, here's another source of information. CYP enzymes and the uh, relative proportion of medications that are metabolized by those enzymes, and whether or not they're subject to major polymorphisms. With the 2D6, as I said, an important enzyme with regards to the metabolisms of psychotropics. About 20 to 30% of drugs are metabolized by the 2D6, and they are subject to significant polymorphisms. 2C19, about 5% of drugs are metabolized by the 2C19, and again, some polymorphisms, are um, do occur. 3 and 4, much more likely to be inducible by diet, not as much subject to genetic polymorphisms, but very, very important in terms of drug metabolism. Again, 45 or 40 to 45% of drugs are metabolized by the 3A4. Again, rare polymorphisms, very much subject to dietary factors, induction and inhibition. 1A2, again, likely, important, 5% of drugs metabolized, less likely less subject to polymorphisms, but they can occur. Here's another way to look at that data. So this is the proportion of psychotropic medications. We're on slide 106. The proportion of psychotropic medications that are metabolized by individual enzymes. Again, generally speaking, the 2D6 and the 3A4 are going to be the two most important enzymatic systems in terms of psychotropic and other medication metabolism. But the 2C19, the 1A2 are significant as well, and then you see some of the others. So again, just kind of giving you a picture representation of what the other chart said. Here's some examples of subgroup, metabolism status. This is from the Massachusetts General Hospital Comprehensive Clinical Psychiatry textbook, which, by the way, this is a good time to introduce as a wonderful resource, not just for clinical practice, but for studying for your PEP. So the Massachusetts General Hospital Comprehensive Clinical Psychiatry textbook, and psychiatry board preparation. Um, um, Not the textbook, but the book or the resource can be very helpful if you want to take note of that. I'm sure you can find a used copy somewhere. But it's really also, it's helpful to get a hold of the testing examples. I don't know if you have to buy, like a certain subscription or something like that to be able to take the online test, but they can be very helpful in preparation for the PEP. Anyway, so again, some information about genetic polymorphisms in different populations, including, for example, in the 2D6. This abbreviations are listed at the bottom. IM intermediate metabolizer, PM poor metabolizer, SCM super extensive or fast metabolizer, and SM slow metabolizer. So, I mean, this is slightly term different from what I showed you before. In the end, you want to remember slow, fast, or ultra rapid, and the intermediate or extensive, quote unquote, being the normal or the average metabolizer. So what does this mean and when is this important? When we move to slide 108, you'll see I'm asking you to consider, does it really matter, right? When is drug metabolizing status clinically important? Do we test everyone? Do we test no one? Or do we test some people sometime? And or do we test at all? That's a question that we're going to talk about later. But is it important to know someone's drug metabolizing status? The drug metabolizing status is important when a drug is widely used. And it has certain aspects. So a drug that is widely used obviously would be prescribed would be just as likely to be prescribed to a poor metabolizer versus a fast metabolizer. And that's why this may be important. When a drug has significant plasma concentration related side effects. The TCAs are a good example of plasma concentration related side effects. You probably have heard about TCA toxicity, uh, and um, and so, or therapeutic drug range, which is the next bullet we'll talk about. So if if the plasma levels are too high and the side effects are intolerable, then you want to know the metabolizing status of the individual because they may not be able to tolerate it. When the therapeutic range is narrow, so a good example of a narrow therapeutic range. Well, maybe not. Let's put that off. But if you have you have a drug, but that for who, for which the therapeutic range is very small. It's really only effective at a certain therapeutic drug range. Then again, metabolizing status would be very important. I guess a good example would be, Celexa and or citalopram and citalopram, Celexa and Lexapro, and that they have a very, very small therapeutic range. When few therapeutic alternatives exist. So on the other hand, when a drug is widely used, if a drug is one of very, very few alternatives, and does have, potential for side effects or non-efficacy, which would be just as important in the treatment of medical problems, then a metabolizing status, check could be useful. And obviously, if the drug does not work as intended, or the person is experiencing significant side effects, the drug metabolizing status of the individual may be something to consider. Okay, so we're going to talk about this case report from two different perspectives. Initially, in this class, we'll talk about it from the perspective of understanding how genetic polymorphisms can be different for different individuals and what that may turn into. So this is from a book case report. So I don't know if this is a real case, but um, I would imagine it is so. Where an infant died because their breastfeeding mom was put on codeine. So the mother was determined to be a 2D6 so ultra rapid metabolizer. And as you probably recall, codeine is a prodrug. I mean, it has to be broken down by the liver enzymes before the active form of the drug, the morphine-like, or the morphine really is available. Um, and this ultra rapid metabolizing mom converted the coating into morphine more rapidly and completely than other people. Of course, this, results in higher than expected serum levels and breast milk morphine levels, which is what mattered in this case example. So of course, this raises concerns about nursing babies being at risk of morphine overdose, or really, potentially true with other drugs, if their mothers are taking codeine and they are ultra rapid metabolizers. Um, let's look at it, again from a visual perspective. This is a prodrug, codeine, converted by the CYP2D6 into the active drug, which is morphine. And morphine is the analgesic. Morphine is the drug that actually, has an effect on the body, the effect of pain relief. Whereas an ultra rapid metabolizer again would do so more rapidly and completely, and therefore would have higher serum levels of the drug um, in their in their blood and in their breast milk. A, a poor metabolizer lacks the analgesic response to codeine, so they would not be able to break it down. So it would be the kind of the opposite end of this spectrum. And just think about it from a potentially cultural perspective. If you are if you're faced with somebody who may be viewed as potentially drug seeking, because they lack, because they report lack of response to something like codeine, and they may be viewed as drug seeking because they're in actuality a poor metabolizer, and they're not able to break down the drug and benefit from the analgesic response. Okay. Uh, This is slide 111, and this is just another way to look at what I just mentioned by looking at the area under the curve. So, as you may recall, the area under the curve is the overall amount of drug in the bloodstream after a dose. Um, so you got, the darkened line would be hold on, let me see if I can. Yeah, so the grayish line, the light colored line before would be the expected AUC, the expected area under the curve. And the dark line would be the actual area under the curve. So you see with this medication, let's say the previous medication was medication X, so we'll make this medication Y. The standard dose is 2 tablets. A poor metabolizer, so somebody who has two non-functional alleles, or one deleted, one non-functional, would require 1 tablet. Again, not a real drug, so don't take this too hard. And even with just that dose, the area under the curve would be significantly higher than that expected AUC. An intermediate metabolizer may require 1.5 tablets, and even with that, again, their AUC would be slightly higher than expected. The extensive metabolizer would use a standard dose. They would have the expected response, or the expected AUC after one administration. And then the ultra rapid metabolizer may require, 3 tablets, and their expected, or their AUC is much lower. So about the amount of the drug in the bloodstream would be much lower after one standard dose, just because it would go through their system so much faster. So I do want to point out, this sounds like I'm saying the opposite of what I was saying before with codeine. The difference is that, again, the fact that codeine is a prodrug means that the liver is required to metabolize it in order to turn into the actual drug. So that metabolism, or that breakdown, would lead an ultra rapid metabolizer to, shoot up their drug levels because they metabolize quickly, whereas a poor metabolizer would have decreased blood levels. With a normal drug, it would be the opposite. The poor metabolizer would have a higher than expected drug blood level, whereas the ultra rapid metabolizer would have a lower level of the drug. Okay. Um, here's here's just another way to look at it. This is lack of, this bar represents lack of, or this graph represents lack of drug efficacy at the bottom. Normal, efficacy based on the same drug concentration and drug toxicity. So as you could see, much more, slow metabolizers, much more likely to experience drug toxicity at the same therapeutic dose. Um, Ultra rapid metabolizers, much more likely to experience lack of drug efficacy, after one or two doses or at the standard dose. Sorry. Okay. So here's an example of how that might you might see that in practice. Not you, per se. This is more of a GI example. The proton pump inhibitors, the PPIs, such as Nexium, Prilosec, and Prevacid, um, basically drugs that are used for the treatment of H. pylori infection and peptic ulcers, or gastro GERD, gastroesophageal reflux, that sort of thing. Um, they tend to have 100% treatment rate, meaning response in poor metabolizers, 60% treatment rate in patients with heterozygous genotypes, meaning uh, uh, one, each of the alleles is different from the other. So one may be functional, the other one may be non-functional or a variant, and 29% uh, in patients with homozygous wild type, so non-mutated. Um, and here's one explanation of why that might work. This is just one example, again, not anything that is particularly relevant to um, our clinical practice, but just to give you an example of how those metabolizing status might turn into different rates of response when we're talking about specific medications. Um, in the next few slides, we're going to talk about specific polymorphisms in different systems and what that may mean in terms of psychotropic medications. So these are important slides coming going forward. I want you to focus on the most commonly used psychotropic medications. If there's anything you're going to be tested on the exam, is again, what is most commonly seen in clinical practice, including the SSRIs, some of the second generation antipsychotics, and some of the newer agents, as opposed to and to some extent the tricyclics. Believe me, you'll be asked questions about the tricyclics and the PEP. I remember a question about which tricyclic would be most helpful for someone who is essentially an older adult with cardiovascular problems. And your response to that question is none of them. Absolutely not. You would not want to, increase their cardiovascular risk of an elderly individual by giving them a tricyclic. But what they want you to know is the nuanced difference between the tricyclics and which one of them would be essentially the least of all evils. So to some extent, you do need to know some of that. Okay, so let's look at slide 114. Here's a long list of psychotropic medications that are metabolized by the 2D6. As I mentioned, I think somewhere between 25-30% of all medications are metabolized by the 2D6. This is not an exact number, but just know that it's a considerable number. And then a lot of psychotropic medications. When I list here, at the bottom that the TCAs have secondary metabolism by the 2D6, um, and tertiary by the 3A4. That's just FYI. So just keep in mind that while medications on this list are primarily metabolized by the 2D6, there are other medications that have secondary or even tertiary um, effects. In By the way, I don't know if you guys have been introduced to Hippocrates, and you can ask me questions about it, or tell me more about it in the live lecture. But Hippocrates and Medscape are good sources of information about the specific metabolism route of different drugs. So if you don't know, because nobody's going to memorize all of this, which enzymes or enzymatic systems are responsible for the metabolism of a specific drug that your patient has taken or that you're about to prescribe, you can look it up on Hippocrates and it'll tell you. Okay, so you could see lots and lots of, psychotropic medications, old and relatively newer, or, medications that are currently commonly used, like venlafaxine and duloxetine, and atomoxetine or Strattera, and a few others. For the antidepressants, specifically, some of the new agents that are metabolized by the 2D6 newer include Trintellix or vortioxetine, fluoxetine and paroxetine not being so new anymore, definitely not new. And other medications like iloperidone or Fanapt, a antipsychotic, um, has extensive metabolism through the 2D6 as well. This is kind of what I mentioned before. With newer medications, you could just easily look up that information. Okay, so that was a 2D6. Sorry, I don't know if I told you how many people are poor or ultra rapid metabolizers on the 2D6 here, but I do want to make a connection to the previous slides that we reviewed. Let me go back. Slide 104 list, again, take it with a grain of salt, but has some data with regards to the proportion or the relative prevalence of genetic polymorphisms on the 2D6. Slide 105. Also, I don't know. Well, it doesn't really tell you the prevalence, so not slide 105, but 104. Slide 107 gives you some relative prevalence of polymorphisms on 2D6. So I want to refer you back to that. As we move on to slide 116, where we talk about genetic polymorphisms on 2C19. So as you can see, about 3% of Caucasians, 3%, about 3% of Mexican Americans, 25 to 25% of Japanese, 20% of African Americans are indeed poor metabolizers on the 2C19. Here's another chart in 117 where that talks about prevalence in other subpopulations. This is by country, for example, Caucasians, not just in the United States, but Canada, Denmark, France, so on, and Latinos, specifically in the US. But, as an example, East Indians, not in the US, but in India, Chinese and Japanese. In the number of studies and is essentially the proportion of individuals that were um, poor metabolizers essentially in this 2C19 system. And just want you to take a look at the relative prevalence. Again, some of these for where it may land in the 2 to 3% range in Caucasians, maybe as high as 20%. Or 21%, 20% in Indians, 21% in Japanese. Here's a list of medications that are metabolized by the 2C19. Again, you'll see some old and some newer. Again, not a lot of new things under the sun recently, but here's some newer medications. What's in parentheses is other systems that they also part of their metabolism. So they're also metabolized by other, subsystems of the P450 enzymes. But they are metabolized by 2C19 primarily. Those include again, some of the older, like mitriptyline or Elavil, and some of the, some medications that are, slightly newer, like modafinil. Um, let's see what else we got. And then we see some inhibitors and inducers. Inhibitors and inducers. These are not, I'm sorry, I want to clarify, these are not medications that are necessarily um, um, not necessarily gonna be contraindicated, but you gotta watch out for that inhibition of the system and adjust your dosing accordingly. So things like topiramate or Topamax, Paxil and Prozac, Luvox are inhibitors. Inducers include carbamazepine and prednisone, basically steroids, and a couple of others that you see there. So foot stomp on this slide 119. As we reviewed before, 1A2 and 3A4 rarely have genetic polymorphisms. They do sometimes, but they don't necessarily translate into, differences in metabolizing status. They're mostly affected by environmental, including dietary factors. 2D6 and 2C19, sorry, I said that backwards, but that's the same. 2D6, 2C19 are mostly under genetic control. So those are going to be the two systems that are most likely to show genetic polymorphisms. Those are the two systems that we're going to focus on mostly with regards to genetic testing or phenotyping. Whereas 1A2 and 3A4 are, like I said, mostly affected by environmental, including dietary factors. And that's why you see that, for example, people of Africa with that move to Western countries and change their diets may have different responses to medications because, this factors can affect their metabolizing status. So again, there may be some polymorphisms with 1A2, but there are no reliable inter-ethnic differences that have been observed. One study showed that 12 to 13% of Caucasians, Asians, and Africans are poor metabolizers. These are also highly inducible by, once again, dietary and behavioral factors. They're also inhibited by some dietary factors like diet corn and high carbohydrate consumption. So think about, what is culturally relevant here about potentially diets that are high in, charbroiled beef or, high proteins or cruciferous vegetables versus diets that are high in dietary corn and high carbohydrate consumption. One example being a diet composed of heavy starch diet, so what some people would argue um, is part of the Mexican diet. Um, okay. 1A2 drugs listed on slide 121 include some antidepressants, some antipsychotics, again, including some of the quote unquote newer ones like ziprasidone and asenapine or Safras. So again, for what it's worth, patients on this medications, we really should ask questions about their diet. There's other drugs that are not psychiatric drugs, but that are commonly used and you should know about because some of them are psychiatric drugs like Zolpidem. But solmitriptan, it's a drug used to treat migraine headaches or, cluster headaches. Melatonin, commonly used, supplement that people sometimes use without telling you for sleep induction or maintenance. And certainly things like acetaminophen or caffeine can affect 1A2 metabolisms. And here you see some inhibitors and then some inducers. And then just keep in mind what this means. So from a practical perspective, induction means basically the speeding up the metabolism. So making it so that uh, less of the therapeutic dose, less of the therapeutic effect may be present for high metabolizers. Um, okay. 3A4 is the exception, as I mentioned before, and that is not a subject to genetic polymorphisms. They're quite rare. Again, 1A2, you see those polymorphisms, but they don't really have any significant clinical impact. What you're looking at is a very important system when it comes to the metabolism of a lot of pharmaceuticals. So roughly 40%, again, you'll see different numbers in different slides. Not too concerned about the exact numbers. All I'm concerned about is that you understand the relative importance of the 2D6 and the 3A4 and how they vary in terms of, being subject to genetic polymorphisms versus not. As well as their similarly for the 2C19 and the 1A2. This are readily inducible by other drugs as well, not just diet or, things like alcohol or tobacco. But carbamazepine, you've heard of carbamazepine inducing its own metabolism. These are issues that could cause problems, especially with things like, concurrent use of birth control, and that sort of thing. Could also be inhibited by foods. And, I mentioned some foods already that could inhibit the 3A4. Again, think about from a cultural perspective how this foods may be a relatively low versus a relatively high part of the person's diet, of the individual's diet. Um, Okay, so you probably have heard about this already, but I'm going to bring it up here. And again, not on the slides because they're not going to be tested on it. It's not, it's something you can easily look up. When we talk about foods with tyramine, you've heard about them in the context of the mono. Uh, Sorry, why am I having a little bit of a senior moment here. The medication contraindication for a specific type of antidepressant medication. And this can include things like strong or aged cheese, cured meats, smoked or processed meats, pickled or fermented foods. Again, I want you to listen to this list from a culturally relevant perspective. Fermented foods, some examples of that include sauerkraut, kimchi, caviar, tofu, pickles, sauces, including soy sauce, shrimp sauce, fish sauce, miso, and teriyaki sauce, soybeans, snow peas, fava beans, ripe or overripe fruits such as dates or raisins, or um, overripe bananas or avocados, uh, yeast extracts, and meat tenderizers. Again, just to give you an example of the things that could potentially bring about induction or inhibition, uh, or certainly inhibition when it comes to the 3A4. If they are constitute a large part of the individual's diet. So we think grapefruit quite a bit because that's been sort of hammered into us from other classes, but there's a lot of again potentially culturally relevant food and food choices that could potentially affect the metabolism of 3A4 drugs. Here's some examples of 3A4. Um, okay, just took a moment to look ahead to see what a good stopping point may be. So again, some new, some old. Vilazodone is Vibrad. Um, It's metabolized extensively by the uh, 3A4 as a primary, but it's also metabolized by the 2C19 and the 2D6. So, just keep that in mind. They're not, usually it's not one single system that we have to worry about. We have other classes of medication, including the C drugs, the sedative hypnotics, including some of the benzodiazepines and the sedatives like zolpidem or Ambien, and other medications like carbamazepine, aripiprazole, and quetiapine. And so just to give you an idea how some common medications may be affected by this. Sorry, I feel like I'm losing my voice. So I just want to highlight, and again, this is something you've covered in other classes, so I'm not going to delve too much into it. But it's also important to highlight that metabolism occurs through phase 2 as well. If you take a look at let me stop here. We'll continue on this subject when we come back from a short break, but we're on slide 125. I haven't just covered the 3A4 drugs, so I'm gonna stop sharing and take a short break. All right. We're going to resume with slide 120, 125, really 126. I mentioned metabolism occurring through phase 2, meaning not the cytochrome P450 system, which is considered phase 1. And if you remember this graph, this is a little bit off, but this graph from a previous slide, again, the majority of metabolism does occur through the CYP450 system, but there is a metabolism that happens through the UGT1A4, the COMT system, DOPA decarboxylase, and the aldehyde oxidase, which is primarily responsible for the metabolism of alcohol. That it may be important for certain medications. So the UGT, for example, on slide 127, is a glucuronidation, or phase 2 metabolic process, is a common pathway in the formation of hydrophilic drug metabolites. Hydrophilic meaning water, water-like. And there are at least 33 families of UGTs. They have a nomenclature. The reason you haven't heard about it in other classes, probably not as much, is that there's less information about how they may impact, how those polymorphisms may impact specific, or may have different impacts on specific drugs. But there's at least 3 families of UGTs, and they have a nomenclature that is similar to the CYP450. But the most important ones are UGT1 and UGT2, so it's unlikely you'll ever hear anything about the other 31 subclasses. There's extensive variability in the UGT1A1 specifically across ethnic groups. But again, the clinical significance of variance is unclear. It's not well studied. It may not be, or it's thought to be not as important as the phase 1 cytochrome P450 metabolism. But it is important for the metabolism. The UGTs are important for the metabolism of certain drugs. So, for example, the primary, secondary, and tertiary amines are metabolized by UGT1A4. Clozapine, olanzapine, and acenapine are metabolized by the same UGT system. Some of the benzodiazepines and also some of the mood stabilizers also have UCT or UGT metabolism. Once again, if you're curious, if you want to know about specific drugs. Hippocrates or Medscape are a good source of information about the metabolizing pathways for specific drugs. So, we've covered the main cytochrome P450, so phase one, and also some of the phase two metabolism pathways. And this may be the time as we go through, go onto slide 130, where you think, so what do I do? What to do? Right? We know that there are polymorphisms on those systems that show ethnic differences. However, the overlap is great enough to limit its usefulness in individual patients. And, I take note of the fact that genetic testing is available and can give us useful information. It's not where it should be, and that's what we're going to talk about in this segment. But what do we do? What did we do before genetic testing, and how do we accommodate for its limitations? So you remember this, right? Remember that despite polymorphisms, organisms adapt to their environment, and also that the environments affect genetic expression. So those are the kind of things that we need to consider when we talk about phenotyping or genotyping. Um, in general, the FDA hasn't had a strong argument for genotyping or pharmacogenetic testing, except on rare occasions, and they have sort of uh, fallen on the side, or weighed on the side of safety as opposed to efficacy, because really it's not their job. The FDA really is tasked with providing information about safety of drugs. Of course, efficacy is important, but they're not supposed to help prescribers choose. They're supposed to, warn against, potential problems to some extent. That's not, their entire mission, but that to some extent. So, um, in general, the FDA has primarily chosen to use safety information on pharmacogenetic testing in order to prevent what may be rare but severe adverse effects of drugs. Even when the association is very, very rare, they want to make sure that prescribers are warned of potential risk, like I said before, and that they make, their clinical decision making is enhanced by this information. They really have placed the burden on clinicians to use their own judgment if they're going to use a medication, and or if they're going to use pharmacogenetic testing before prescribing a drug. Um, in contrast to the FDA, prospective trials and of genotyping are used to, try to avoid adverse pharmacogenetic effects. Um, let's talk about genetic testing or genotyping. We're going to talk about genotyping and phenotyping, and I'll share with you what the differences are. It'll become clear as we talk about it. So genotyping basically is looking at blood sample or saliva for specific genetic alleles. And so, in most, without genetic testing, the standard approach would be start low, go slow, and get blood levels in order to determine, for example, a therapeutic drug range, or to assess levels of potential toxicity for a specific patient. But with genetic testing, prescribing can be tailored, or is thought to be tailored to the individual. And as I mentioned, the FDA has focused on safety. So the FDA does recommend, and this is an important thing for you to know, genetic testing or genotyping Asians, especially Han Chinese. We talked about that in the previous segment for this specific allele, the HLA-B1502 allele, if they are being considered for treatment with carbamazepine. In practical terms, they the prescriber, that does have access to genetic testing is going to use this recommendation. If they don't have access to genetic testing or the patient doesn't have access to genetic testing, they're probably going to choose a different agent. But the reason, as I mentioned earlier, is because there's a significant relationship between carbamazepine use and the induction of Stevens-Johnson syndrome and toxic epidermal necrolysis, or TNS, for carriers of this allele. So, again, this is a very serious but also very rare side effect. So this would be an example of safety genotyping. So let's talk about genotyping devices. And, this is all, publicly available information from the internet. So I'm not endorsing in any way, shape, or form any specific device. I'm trying to gather some information to give you an idea of what this is like and how it's used. And then kind of go from there. First FDA approved genotype device was the Ampli chip, and you saw a previous slide that sort of gave you some information from these company, this pharmaceutical company. Can genotype for polymorphisms and multiple copies of two cytochrome P450, specifically the two that are more subject to genetic polymorphism. So that's why when you see the information about this devices, you're not going to see 3A4 or 1A2, because they're not either they're not subject to genetic polymorphisms, or their polymorphisms are not as important from a clinical perspective. So, and in their data, they share that about somewhere between 5 and 10% of most populations who lack 2D6 alleles are poor metabolizers of tricyclics and typical antipsychotics, while those with 3 or more copies are ultra-rapid metabolizers and may not respond to some medications. We already kind of knew that, but that's information that they have in their publicly available data. I don't think I have the information. No, I did not update it for this specific genetic test, but you can look it up. You can look up their price. You can look up, what insurance covers it, and whether or not they provide any kind of assistance or relief for the uninsured. Here's another example, the GeneSight test, trademark is GeneSight. And again, this is a direct quote from their, publicly available advertising materials. If you're suffering from mental challenges, the last thing anyone wants to go through is a lengthy trial and error process with multiple medications. That's the start of it, and that's the sell, right? Fortunately, the GeneSight genetic test can provide doctors answers that quickly lead to relief. And this doesn't tell you what specific, cytochrome or P450 systems they're looking for, but they do tell you it is the cost for Medicaid and Medicare users is none. For other insurance, it could be up to 330 per patient, and this number is a couple years old. That may have changed. And for the uninsured or out of pocket is about $1,500 a pop. Sure Gene is another example. It came out in 2012. I want to say the Ampli chip was 2006, maybe 2000. No, maybe a little bit older, like 2008. Sure Gene. Again, this is a direct quote from their materials. They test for antipsychotic and antidepressant response, consistent with the STAR D. I'm sorry, the ST doesn't have anything to do with the STAR trials, the STAR D trials. So it's just that's the registered trademark for their test. A breakthrough pharmacogenetic test containing genetic markers for effectiveness of an antipsychotic drug treatment. provides clinicians with valuable new information to facilitate individualized treatment, apparently. So the STAR or STA2R, again, more information from them. They share clinical studies in Caucasian schizophrenic patients have indicated that SULT4A1 positive patients treated with olanzapine have greater reduction in psychotic symptoms and a significant lower risk of being hospitalized. And you can look at this for yourselves. They don't publish their cost or insurance, coverage. So I guess it would be, um, yeah, it'd be on the need to know for either prescribers or for the patient if they're doing their own research. This is an example of a genetic testing report. This is from Mental Health DNA Insight. By Pathway Genomics, I identified genetic variants that affect the metabolism and efficacy of psychiatric medications in general. So it's purported to report. If you see the entire report, it has more, as you see listed on the slide, more than 50 antidepressants, mood stabilizers, and antipsychotic medications. Again, the cost is roughly 330 for insured patients. And here's an example of a sample report. And you have probably seen this if they use genetic testing in your clinical practice or something like it. What it does is it breaks down the report by drug class and the different medications in that class. And it gives you a green, orange, or yellow, or red dot on whether or not that medication is advisable based on safety and potential efficacy. So, for this sample report, citalopram, fluvoxamine, and paroxetine may have significant limitations, which may mean they're not as efficacious, or maybe produce some adverse effects. Escitalopram, sertraline, and vilazodone, it says use as directed, and that would be it basically saying use the standard dose. But it does have the potential for telling you which agents would be of preferential use and which agents may cause serious adverse effects. UScript is another example. Again, cost unknown, identifies at-risk individuals for, let's see, potential drug to drug and drug gene and cumulative drug interactions based on both cytochrome P450 metabolism and genetic testing. So this is a little bit more in that you may not see the drug to drug and drug to gene. Well, you would see the drug to gene, but you wouldn't necessarily see drug to drug potential problems in some of the other genetic testing. There's other genotyping devices, that are available. I'm sure there are many more, so this is not at all an extensive list that are more focused, or tend to have a more kind of a single focus. For example, if you look at PGX Predict, specifically predicts clozapine-induced agranulocytosis. So this may be a useful tool. If you have a treatment-resistant case of psychosis that you want to consider using clozapine. As you know, this is a difficult to monitor, difficult to manage, difficult to treat drug that has the rare but potential side effect of granulocytosis, which could be lethal. And so predicting and thus avoiding that side effect may be quite useful. The physiotype system is specifically a test for metabolic syndrome. And I would say, based on clinical experience, questionable usefulness, because there are other ways that you can assess for or predict metabolic syndrome, as you probably know. So here on slide 142 are some sort of translatable uh, or practical, examples of what genotyping in action may look like. For example, genotyping the 2D6 cytochrome CYP450 system in antipsychotics, it has yielded information that where poor metabolizers should be treated with approximately one half the dose. So this is definitely more specific, right? Remember those graphs where I showed you either, 100, 500, or 10 milligrams of medication X, or 2 pills, 1 pill, 3 pills of medication Y or whatever. Those really don't mean anything. Those numbers really are just examples. This is very specific information. If you have a 2D6 for metabolizer, they required half the dose of phenothiazines. They should be not as specific, clearly something that we would know already, but we would be able to determine that a poor metabolizer should be treated with lower doses of haloperidol, and that it should be avoided altogether in ultra-rapid metabolizer. So that's a more practical application. With risperidone, 2D6 poor metabolizer should be treated with approximately one half the dose. And again, I wouldn't make any generalization about other agents, even in the same class, based on that information. And ultra-rapid metabolizers may need higher doses, but this has not been well studied. So, this would be an area where what you would expect may not necessarily be what you see. Individuals may have individual responses. So an ultra-rapid metabolizer may or may not need a higher dose of risperidone. And you want to be careful because, as you know, risperidone has a high risk of metabolic syndrome. So you'd be cautious about increasing the dose any more than necessary. For the antidepressants, here's some practical findings. Poor metabolizers on the 2D6 and 2C19 should be treated with approximately half the dose. And again, because we're talking about the TCAs, higher doses under therapeutic drug monitoring. So, essentially taking a blood test to help you determine the relative serum concentration level can be considered for the ultra-rapid metabolizers. And ultra-rapid metabolizers may need higher doses. Again, this is one case where it wouldn't necessarily be you would not be able to make that, to know that for sure. Okay, so that's genotyping. One thing that I will say, and this is a question I get asked, and every time I teach the class or every time I interact with any students or anyone who's not seen this in clinical practice, and again, you may already be seeing this in your system of care. There are some cons again, genotyping, and we'll talk about them briefly. But the reality is that the state of the art, or the recommendation from the American Psychiatric Association at this point, it is not to recommended for widespread use. It is useful and it can be used, potentially should be used in certain situations, but it's not recommended for, it's not considered the standard of care for all patients. Okay, phenotyping is a little bit different from genotyping. It's quite different from genotyping, actually. It requires the administration of what are called probe drugs. So, I want to point out the difference with prodrugs, PRO, like codeine. These are probe drugs. And here are some examples: aspartame, dextromethorphan, so DM, and a couple of others. The pro of phenotyping is that they're not invasive. The way that this is done is, because of these drugs have, metabolic pathways or, timelines that are very well known, very well studied. The person is given one of these drugs, and then they, you kind of follow to see how long it takes, or what um, area under the curve serum level concentration occurs, which can give you information about whether the person is a slow, extensive, or rapid metabolizer. The pro is that it's not invasive. Again, you just administer the drug and watch, take a blood test or a serum level test to figure it out. So it's not, may not be as um, um, labor intensive and costly as genotyping. The con is that you got slower results because you actually have to, for drugs that have active metabolites and, things of that nature, you kind of have to wait and see. Um, so uh, here's some, some other results associated with both phenotyping and genotyping with regards to certain drugs. Venlafaxine, not sufficient information to provide dose recommendations for CYP2D6 phenotypes. Paroxetine, no clear data on relevance of the different 2D6 phenotypes. Same thing for sertraline. Um, For other antidepressants, including citalopram and escitalopram, there are some dosing recommendations. So poor metabolizers may respond better to average doses. As I said before, citalopram and escitalopram really don't have a big dosing range, so it could be fine. And ultra-rapid metabolizers may need higher doses, so you might have to go over the standard dose. Um, so just kind of keep in mind that someone who is intolerant to a lot of antidepressants or a lot of medications in general, because a lot of other medications are metabolized by the same systems, may be a poor metabolizer on those two systems, not just a one system, but in the two systems. Apparently, this is quite rare. Less than 1% of in all ethnic groups are poor metabolizers for both of these groups. Whereas you saw numbers as high as 20% in one specific enzymatic group. And in that case, you want to look at medications that are not metabolized by those systems, or that maybe have, uh, maybe more, um, what's the word I'm looking for? More diverse, in terms of their metabolism. And mirtazapine or bupropion may be a better choice for somebody. So, you got somebody who's reacted or had intolerant or poor response. So intolerant is in side effects, intolerant or poor response to SSRIs, SNRIs, or some of the other, like even TCAs, then you might consider mirtazapine or bupropion, and you might be able to see a response. So, I mentioned before, I kind of give you the punchline already, but, this is where we talk about whether we should do it or not. And I've already told you the APA, the little APA, does not necessarily consider it the standard of care. Not yet anyway, although it may be helpful in some cases. But let's see why or why not. So here are some of the pros. The genotyping can help us to predict, or genetic testing in general can help us predict therapeutic failures or severe adverse reactions rather than the trial and error, which is what we did, right? And this is what we do. We ask patients if they have personal or family experience with a certain therapeutic drug or a certain therapeutic class, and we go with that because it's the best information that we had. Or we start with a medication that we think is going to be beneficial, either from their benefit profile or even the side effect profile. A medication that is sedating for somebody who's having serious trouble sleeping, or a medication that is activating for somebody who has significant anergia or anhedonia. Um, or and that sort of thing. Um, and then try something else if that one doesn't work, or if they have intolerable side effects. That's trial and error. And it is costly, and it can be difficult in terms of drug or therapeutic alliance and therapeutic adherence. Um, it can help where the loss of the drug effect may be dangerous. So, for medications that require steady dose, and or, because losing the effect may be dangerous, such as some of medications used in general medicine. Uh, Genetic testing may be useful. It can help us optimize drug choice and dose for effectiveness. So again, the avoid the unnecessary trial and error, potentially leading to lack of adherence if the side effects are intolerable. Professional leading potentially leading to over prescribing, meaning using more medication than is necessary, or under prescribing. So, we can potentially start with a specific drug, or lower or higher doses from the beginning, and avoid those pitfalls that could potentially hurt our therapeutic alliance, like I mentioned before. 149, some of the other cons. Um, you can avoid very serious adverse side effects or adverse effects, especially when using drugs that have a narrow therapeutic index, like I mentioned earlier. It may decrease medical costs. That trial and error is costly. Potentially you may see somebody give up on it, or you have to have more frequent visits if the medication is not working. You may have to have more frequent and those visits may require a copay, which, the patient may or may not be able to easily afford. Or, even the prescription copays, for medication that may ultimately be wasted if the side effects are intolerable. So, let's say that they have a copay, for their medication, they have a copay for the visit, they experience a negative side effect, and now, both the patient and the insurer are out of money for a medication that is not that that will not be continued. It might help us appreciate the potential risk of polypharmacy. As I said before, some genetic testing does give you information about potential risk of polypharmacy. Plus, even if it doesn't specifically describe risk associated with polypharmacy with specific, with two or three or more specific drugs, if you know that the person is on, poor metabolizer in the 2D6, then you would know to avoid prescribing two agents that are metabolized by that system together. Um, and that's something that, could potentially be useful for a lot of patients, because as you know, polypharmacy is not that rare. It can also help avoid stereotyping patients. As I mentioned before, just think from a minority group perspective, the potential impact on therapeutic alliance if a provider is making assumptions about a patient being either a whiner or complainer because they're not responding to treatment, or they're having multiple side effects to multiple medication trials, being labeled as resistant, or yes, resistant would be uh, an appropriate term, um, that and or creating certain barriers, or on the other spectrum, potentially labeling somebody as drug seeking, because again they are having very little to no effect of a drug, for example, such as a painkiller, or even a stimulant medication, or uh, something along those lines. Um, so those are would definitely be potential benefits of the use in this type of technology. And here are the cons, because I have to present you with both sides. In reality, it might give us a full sense of security. Um, and I'll tell you why. As it's because of what I mentioned before. If you remember that, that wheel, that genetic wheel, there's bi-directional relationships between genetic composition and environment. So, genetic testing is only giving us truly half of the picture, the genetic composition. It doesn't take into account that the addition of an inhibitor, whether it's from diet or, potentially from another drug or herbal substance, may change the metabolizing status, may turn a poor metabolizer into a normal metabolizer or an ultra rapid metabolizer into a poor metabolizer. Um, we do not know how accurately genotyping predicts metabolic capacity. So, we are um, flexible and adaptable uh, organisms. There are ways that we compensate. So it does not necessarily predict total metabolic capacity. Probe drugs also do not correlate perfectly to metabolic capacity. So, there may be one one answer, but it's an incomplete answer. And it doesn't tell us what to do with drugs that have active metabolites. Um, yeah, so it just simply doesn't. Um, as I mentioned before, we are flexible, we're adaptable, and we create compensatory mechanisms. So significant side effects and toxicities do not always occur. And that's why when I said before, when I was talking about the different practical applications, with some of the 2D6 drugs like risperidone, you may not necessarily need a higher dose for ultra rapid metabolizers. Or maybe why, it may be part of the reason why, because the body creates different systems or different ways to compensate for our potential deficits. Toxic episodes are not necessarily eliminated by starting with lower doses. In some situations, it may not be low enough. Like I said before, my supervisor used to say some people can't even lick a tablet without developing side effects, and that's not necessarily an exaggeration. Those toxic episodes may not necessarily be completely avoided. But on the other hand, it might also lead us to avoid useful medications or useful augmentation strategies, where again, yeah, just thinking that something might not work would keep us from trying it when in fact it could be beneficial. And it could be potentially the best, have potentially the best effect for patients. Okay. And here's an example on 152 of the what may happen with the addition of an inhibitor. So, like I said, genotyping doesn't always take into account induction and inhibition that could happen as a result of other other factors. But got to take into account that drug interactions can turn a normal or even an ultra rapid metabolizer into a poor metabolizer. This is a good example of commonly known inhibitor, Paxil, on the 2D6 system. So that co-administration will make an extensive or quote unquote normal metabolizer into a poor metabolizer because of inhibition on that system. Which means that in this sample, as you could see in the picture there, this individual would not be able to break codeine into the morphine or the active drug. Okay. Um, so that's um, that's the gist of it when it comes to pharmacokinetics. I'm going to talk about pharmacodynamics next. We're gonna, basically delve into that. And then let me tell you what else is coming up. We have clinical detective exercise that I feel like it's best to do in the live. Um, yeah, the live portion of the class. Last part or last segment for today, we'll be talking about one specific environmental factor, and that is vitamin D insufficiency, deficiency, or sufficiency, and how that may affect drug response. And you may wonder why this is culturally, why this is something we talk about in ethnopsychopharmacology, and I'm going to give you the answer to that as well. But Before we do that, I am going to pause for a moment. And then, like I said, in the last segment today, this section, we're going to talk about pharmacodynamics, and then talk about vitamin D. Okay, so let's resume. And we were on slide 152. So moving on to 153, where we start talking about transcultural psychopharmacology and pharmacodynamics. This is definitely a shorter section than pharmacokinetics, but important nonetheless. Um, this is, as recall, the effect of the drug on the body that we're looking at, and it's mediated by things like, drug receptors, drug transporters, and other molecules that are involved in signal transduction, such as the G protein. So if you remember, specifically drug receptors that have to do with, quite a few psychotropics, but specifically the antidepressants, the 5-HT2A and the 5-HT2DC, and the SERT transporter, or the serotonin transporter. There's also a norepinephrine transporter that is important to consider in this area. So this is a picture of what the transporter looks like. This is from Dr. Stoll's book. If you haven't used it before, or if you haven't referred to it in other classes, here, once again, a recommendation for a good resource. I, again, like pictures, especially those that help me to see, and understand difficult concepts. Uh, so, um, this is from them. Also, I would recommend, if you are able to, I don't know if they still, I haven't checked their website in a while, but there's a website associated with the Neuroscience Education Institute that provides updates, courses, and other benefits. It's www.neiglobal.com. N as in Nancy, E as in Echo, I as in Igloo. So Neuroscience Education Institute Global.com. Again, I didn't try the website before this class, so I can't, don't hold me to it, but if you can get to it, it's probably very helpful. Anyway, so these are the serotonin, the drug receptors, an example of drug receptors, and how, variations in gene sequencing can cause you to have a short allele. The short is the blue one here on this part of the graph, or a long allele. It's kind of orange color on this side. Basically, those two things would translate into different action on the serotonin transporter, which is essentially what helps, um, for the, sorry, the regulation of serotonin. That's what we're talking about. So the serotonin transporter, or SERT, we have some information about genetic differences that translate into different therapeutic responses. So, genetic studies of antidepressant response show that insertion or deletion polymorphism in the promoter regions of the long allele versus the short allele, what I showed you before in the picture, this one here, which are basically part of the serotonin transporter, have different, again, lead to different therapeutic responses. In Caucasian samples, the short allele um, was associated with reduced or delayed therapeutic benefits and increased adverse effects of SSRI treatment. Again, nothing to do with cytochrome P450. This is another, mechanism from a pharmacodynamic perspective in which we could see reduced or delayed therapeutic effect and side effects associated with drug use. Um, in turn, on slide 157, people who were homozygotic, meaning they have similar L alleles, so long alleles, show less fear and anxiety related behaviors. And the prevalence of those homozygotic for long alleles is quite high in certain populations, as you could see. African Americans and populations of sub-Saharan origin, less high, 50 to 60%, 56 to 60% in Caucasians, and very low, relatively low in East Asians. In other studies, the 5-TT-LPR long allele is associated with better or more rapid SSRI response. So if you recall from the previous slide, short allele reduced or delayed therapeutic effects. In some studies, the long allele is associated with better and more rapid SSRI response, and that included 5 studies and done in Europe and North America. However, in contrast, in 2 or 3 studies that were conducted in Asia, the short allele was predictive of a better SSRI response. So this would be a good example of a genetic variation or that has, with significant ethnic variability. Um, here's another example of clinical significance. A combination of 6 polymorphism located on the 2A receptor and the 2C receptor, as well as the serotonin transporter genes, predicted clozapine response to a level 76.7%. This is therapeutic response. So not side effects, not prediction of side effects, but the therapeutic efficacy. So as you can see, this can be, this can be very useful, but it can also be quite complicated because we're talking about, 6 different polymorphisms in both the receptors and the serotonin, the SERT or the serotonin transporter. Okay, now COMT or the catechol methyltransferase system is among the proteins in the synthesis and catabolism of the catecholamines. And we do recognize that there are polymorphisms in this system that are associated with vulnerability to certain diseases, including schizophrenia. Um, and reduction of its activity can be caused by a single mutation, which is present in a large number of whites or Caucasians, people of European descent, 26% of African Americans, and 18% of Asians in one study. Okay, I mentioned we're gonna for all intents and purposes we're gonna skip the clinical detective now. So slides 160 through 162. Should have put them in a different order so we can leave off with that because this is it would be better for us to talk about this in the live portion of the class. So I'm going to jump, we're on 159, I'm going to jump to 163, and we're going to talk about a different environmental factor, and that is vitamin D. And again, I'll make it clear, hopefully, why we're talking about it in the transcultural psychopharmacology class. So, vitamin D deficiency is something that you may or may not have learned about in other classes, but it's relatively common. It's quite common across the population. It's even common in southern states. I practice in Florida. That's where I got my where I initially got my privileges to prescribe. And I test everybody for vitamin D deficiency, and my hit rate was pretty high, even in the quote unquote sunshine state. So it's pretty common among the population. Um, it's we'll talk about dietary and lifestyle factors that affect vitamin D deficiency. But like I said, I want to make sure you understand that it's something that we need to watch out for. And part of the reason is because of what is listed there, vitamin D's role in the brain. But let's start with some facts, some numbers. 50 greater than 50% of psychiatric inpatients in the U.S. Were found to have a vitamin D deficiency. That's pretty outstanding. 50%. It's a pretty big number. Deficiency is quantified as 30, less than 30, and here's the lab value, an MOL per liter, or less than 12 ng per millimeter. I want you to be aware of the fact that different labs, different laboratories, not different lab exams, different laboratories use different ranges, and so it's important for you not to just be uh, aware of the specific number, but also the measure, the actual measuring scale. So in MOL over liters, or NG over milliliters. Um, and there are several randomized placebo-controlled studies that have shown that vitamin D supplementation can benefit depressive symptoms. But if you know anything about how the vitamin D's role in the brain, which we're going to talk about next, you'll find that it could be very useful in other psychiatric conditions as well. Vitamin D can help with cell communication and overall cell function. It regulates the expression of tyrosine hydroxylase, which is a rate limiting enzyme, which helps in the biosynthesis of dopamine, norepinephrine, and epinephrine. It promotes survival of monoemergic neurons through upregulation of BDNF, and hopefully you have learned about brain-derived, having a moment here. Uh, um, Again, you have hopefully you have learned about the benefits of BDNF in some of your other classes. Um, I'm gonna make myself a note because this is gonna bug me, although you probably know what that stands for. And it promotes neuronal survival by inhibiting oxidative pathways. So it really helps with reduction of oxidation, inhibits oxidation, and reduces free radical formation, which is good for overall brain health and cognitive health. So you can, again, the studies do show that it can be beneficial in depressive symptoms with or without use of psychotropic medications. In and of itself can benefit, some of the symptoms of depression, like anergia, and anhedonia and fatigue. But it can also be, a strategy to increase the effects of an antidepressant. Um, Here are some risk factors associated with vitamin D deficiency. Older people, insufficient sunlight. I mentioned even in the sunshine state, we saw cases of, vitamin D deficiency. I've also practiced in Germany, England, and here in Ohio, where, especially this time of the year, we don't get a lot of sunlight. And it's even more common, of course, in places that are above a certain latitude where, sunlight may be reduced, especially during the fall and winter months, or places that are, where a lot of overcast, um, there's a lot of overcast sky. Um, Breastfeeding, dark skin. So this is the connection here, culture, the connection to this class. Dark people of brown and black skin, maybe more prone to vitamin D deficiency. They don't absorb vitamin D from sunlight as well as people with light skin. And a lot of other things, including obesity, which is a common problem in the United States, but also in some of the countries in which some of our patients originate from. Some medications that can alter the metabolism of vitamin D include the anticonvulsants. So there again, another connection to, our patients or the patients that, we may see in clinical practice. And then of course, liver and renal problems or dysfunction can be a risk factor for vitamin D deficiency as well. So one of the ways, and I'm putting this out there, clinical facts and applications as we go through. One of the things that we check for when, again, as a baseline, address whether there is a vitamin D deficiency in a patient that comes in with complaints of depression or really any psychiatric illness. Because, once again, and at least in this study, 50% or several studies, 50% of psychiatric inpatients had it, and you can believe that outpatients do as well. So assess at a baseline. But another thing that we need to do after proper supplementation for somebody who has vitamin insufficiency or deficient is to monitor, because if they have liver or renal insufficiency or disease or problems with absorption of vitamin D, then even after appropriate supplementation, you may not see a change. And that's something you would have to refer to be addressed as necessary. We also get vitamin D from our diets, so not just sunlight, but that's in dairy and other green leafy vegetables and dairy products. And so just keep that in mind for people who say, I get enough sunlight. I go to the beach all the time, or I'm always, I spend a lot of time outside. If their diet does not include, dairy because they're lactose intolerant, or it doesn't include a lot of green and leafy vegetables, they may still not have sufficient vitamin D. And by the way, I mentioned less than 30 is considered deficient. Less than 20 is considered sorry, less than 30 is considered deficient. There's a range depending on what lab you're using that is where it's considered insufficient. But it's a good idea to recommend over-the-counter supplementation for people, especially people with dark skin who don't have a lot of sunlight exposure. And again, especially during fall and winter, primarily during winter months and in some of the more northern latitudes. As I said, several studies have linked it to depression, but also another set of studies have linked to vitamin D deficiency to schizophrenia and other psychotic disorders. Here's some examples of studies in Europe that have found correlation in some association between low vitamin D and psychosis. If you We're going to talk about these in our gender class when we talk about pregnancy and postpartum issues, about birth cohort studies and about birth registries. But this is an example of a finding where vitamin D supplementation in this birth cohort study in the first year of life led to decreased incidence of psychosis later in life. And again, think Finland is very northern country with lot of limitations on sunlight exposure. Okay. Um, Low vitamin D has also been linked to cognitive impairments such as memory, orientation, executive function, risk of Alzheimer's, and there are potential ethnic variations. There is a finding that says that polymorphisms of vitamin D2 receptors have been associated with depression and poor cognitive function. Um, and that's not something that we test for, right? We wouldn't know necessarily that somebody has a polymorphism in the vitamin D receptors. So just kind of, think about that in terms of risk. Um, there's conflicting results with regards to depression, and as I mentioned, there are some potential ethnic variations. Here's some example of a quite large study that showed that higher risk of depression is present for individuals with low vitamin D. Um, Another study, smaller study in the Netherlands found vitamin D levels were 14%, were present in 14% of depressed patients. And or in China, a very large epidemiological study found that no relationship between vitamin D and depression. So again, there are some potential genetic or ethnic variations with regards to the effect of vitamin D. So we do know that at its core, at the basic level, even for non-depressed patients, vitamin D can improve well-being, fatigue symptoms. It can certainly improve, irritability and depressive symptoms in people without without a psychiatric syndrome. I can tell you from personal experience, again, having lived in Germany and especially in England, what a significant difference it made when I was, when I was found to have vitamin D deficiency and was able to supplement and, just overall well-being, energy, concentration, focus, and and that sort of thing. And um, kind of bounce in your step when spring comes along, that is a real thing, for a lot of people. Um, but however, you'll see that there are population differences and conflicting findings. So there's definitely more studies needed to assess the impact of vitamin D on seasonal affective disorder. It is likely that it is a contributing factor. I mean, there's no question that the lack of sunlight, the shorter days, can affect mood and other symptoms of depression. But whether or not is all related to the lower availability of vitamin D is unknown. Okay, so what's the treatment? And again, there may be some variations that are needed based on your patients or tolerability, and this is one of those things that you may prescribe yourself. And I caution you, this is in a clinical setting. So I don't know if you guys have heard about pharmacy and therapeutic committees, or in your clinical setting, if you have a pharmacy and therapeutic committee. Those are the panels, and we'll talk about them more uh, probably in day 3 of this class. Those are the panels that make decisions that not only about what medications are going to be in the formulary for a specific medical center or hospital or clinic, but also about uh, the privileges given to prescribers in that facility. And so at least in my setting, or the settings that I practice, I've been able to prescribe vitamin D um, at at the levels that are necessary to treat vitamin D deficiency. But that may be different in another setting. So keep that in mind. So as you can see, the Endocrine Society and the Institute of Medicine, um, recommends daily vitamin D supplementation to prevent deficiency, especially for people over the age of 70 at different rates, as you could see, but certainly for people under the age of 70. And this is why it is okay to recommend that most people who live, above who have limited sunlight exposure, let's put it that way, in the fall and winter months, supplement with vitamin D. It is not there's no it doesn't really have a lot of side effects or problems. There's not a lot of adverse reactions associated with it, so it's okay to to recommend supplementation to anybody who lives in areas with limited sunlight exposure. And or again, who has dietary limitations prevent vitamin D consumption. For all adults in general, under the age of 70, 400 international units per day. That's typically what if you look at over the counter, um, uh, supplements of vitamin D, typically you'll get about 1,000, 2,000, up to 5,000, even 10,000 international units. You don't need that. You need what's in a multivitamin, essentially. Most people will do okay with, the amount that is present in a multivitamin, but some people will need a higher dose. Again, pregnant or lactating women will need 600 international units per day. The upper limit recommended is 4,000 international units per day. Again, I've seen up to 5,000. But for insufficiency or deficiency, you need 15,000 units per week. And typically it's, one dose, one time a week. So not 50,000 spread over 7 days, but typically one mega dose, one time a week for somewhere between 8 to 12 weeks, and then you want to reassess. And again, as I mentioned before, it is important to remember that that some people actually have problems that may lead to to difficulty absorbing the vitamin D. So if their numbers haven't changed after 8 weeks, in a blood level um, lab, then you need to refer this folks to primary care or endocrinologist. I don't tend to refer to the endocrinologist directly. I refer to primary care because they're responsible for managing those types of issues and referrals. Okay, all right. So this is slide 170. We're going to move on to the clinical detective. And I really just want to introduce it. This is going to be a shorter segment. One, because I promised that I give you extra time to handle the questions associated with the genomics research segment. And two, because I want to give you some time to read and process this clinical detective case. And then to come to the live lecture, next week, prepared to talk about it. Ask questions, but also have answers as to, issues that you would consider or things that might have occurred. So this is a textbook example. I'm back to slide 160. So just so you're not lost. This is a textbook example, so not a patient of mine, potentially not even a real patient, but it could be, certainly. I'm going to give you some facts and then again ask you to think about what questions do you have, what issues do you need to address, what issues do you need to consider. What would you do if you were the treating provider or if you were the consulting provider, where the internist is saying, help me here, and you're the prescriber in the facility that has to provide that that it's in place to provide that kind of consultation. So what we have is a 50-year-old African American male who presented to his internist, so internal medicine physician, with symptoms of MDD, or major depressive disorder. And I want you to, again, start thinking about what we're looking at, right? 50-year-old African American. By the way, this is a little bit of a dated example, but it's really important to highlight. It really does help us highlight some of the issues that I'm asking you to consider. Um, so we have a 50-year-old who presents to an internist. So, that should lead you to question, what is their medical status, that they are, managed, their care is managed by internal medicine as opposed to, a general physician. There was also a past history. So they have symptoms of major depressive disorder. There's a past history of significant alcohol use disorder. We don't know whether it was mild, moderate, or severe, but you can make some assumptions based on the fact that it says significant. In remission for the past 4 years. This person is abstinent. The internist prescribed amitriptyline 75 milligrams orally at night. That's what MGPOQHS means, as I'm sure you guys have, or maybe talking about in a different class. Again, I pointed out the fact that this is kind of dated, so don't freak out when you see amitriptyline 75 milligrams. Assume, this is before SSRIs were widely available, and that's okay. It still helps us to work through this issues. 1 week later, the individual returned with a worsening of his depression, and the internist increases the dose to 100 milligrams a day. The patient is now continuing to deteriorate and then is referred to a psychiatrist who hospitalized. Um, so at that point, the patient is suspicious, guarded, and irritable, and is given a diagnosis of psychotic depression or major depressive disorder with psychosis. Haloperidol 10 milligrams by mouth, so orally, at night is added. Again, maybe not something that you see in clinical practice today. Just take that for what it's worth. Uh, I this one I want to highlight some, implications here, potentially, of things that you already know about uh yeah, this population or the population that this individual belongs to with regards to, presenting as suspicious, guarded, and irritable, and why or how that may lead to inpatient psychiatric hospitalization and treatment with an antipsychotic. 5 days later, the patient is found unconscious in his room after complaining of faintness and heart palpitations. He's rushed to the coronary ICU, or um, and a 2-1 atrioventricular block and periodic runs of PVCs, or um, sorry. So he's rushed to the coronary ICU. A 2-1 atrioventricular block and periodic runs of PVCs are found on the ECG or the EKG. Drug level monitoring reveal a total TCA plasma level of 950 ng/ml. So once again, drug monitoring revealed a plasma level of 950 ng/ml. So at this point, hopefully you have some questions about what's what's the typical drug plasma level for TCAs, specifically for amitriptyline. What are we looking at? So at this point, all psychoactive drugs are stopped. So we're talking about amitriptyline and haloperidol. And as the plasma level falls, the cardiac and psychotic symptoms resolved. I'm not talking about depression. The depression, may or may not have resolved. That's not the issue that this example is asking us to address, but the cardiac and the psychotic symptoms have resolved. So, what happened? And this is what I want you, or I'm asking you to think about. So, for the rest of the time allotted for this lecture, again, I want you to go back to the facts in this clinical detective case. Try to think about it from both a clinical perspective, based on the material that we've already covered in the class, but also, put your ethnopsychopharmacology lens on and think about it from an ethnic and cultural perspective, and talk about, let's be ready to talk about what kinds of tests would you run, what kind of issues this person may run into, what kind of issues actually materialized in the care of this patient, potentially, and what happened to have caused this person to have clear cardiac problems. Um, what I might argue may be, at least we don't have enough information, questionable psychotic symptoms. If they are questionable, why would that be? And I'm kind of hinting at some of the issues that I would consider, but I definitely want you to, come up with some of your own. So again, go back to slide 160, 161, 162, and be prepared to talk about that as we begin the lecture on day two. So with that, this is the end of day one. And I want to thank you for listening to the recorded lecture. Again, feel free to email me, or let me know on the Canvas SharePoint whether you have any questions. And I hope you have a good day or a good rest of the day.